So I want to welcome all of you. I hope that all of you had Thanksgiving, some time to rest. And there's so many things for us to be thankful. And so I hope that you had a great holiday. And certainly from our standpoint here, I want to say to you that I'm absolutely very thankful to all that you do every day. And that we would not be able to do what we do without one of you. So thank you for all that you do. Thank you also for coming here tonight. This is a calibration session, our third for this year. This calibration session will be focused on the posterior teeth, the focus on the preparation, cavity preparation for posterior teeth. This calibration session was put together by Amy Carpenco and Rodrigo Maya with Suman's help. And Andrea. So I wanna thank each one of you for spending time and putting together the calibration session. So we are not gonna delay anything here. So Amy, I feel like we're gonna get started. Thank you again for doing this. Really appreciate it. Thank you.
Okay, Amy, do you want to go over how we're going to play in
Later.
Zoom and here? Okay, later.
So hopefully everybody can hear me. Rodrigo is monitoring the chat for those of you at home. Thank you for coming. Thank you. So today we are talking about specifically posterior preparations related to the restorative test cases, in particular in VIX. But before we do that, we've got a couple.
No. Okay. No. Keep going. Keep talking.
Okay. So we've got a couple goals today. One of the things we are going to do is briefly go over some of the preclinical concepts for their posterior preparations. We've had a chance to talk to the preclinical instructors, just so that we can give a lot of the clinical faculty the background of what the students are learning, so to help bridge that gap between pre-clinic and when they come up to the clinic, some of the terminology and things that they're being taught in relation to their preparations in pre-clinic. We'll do that pretty briefly. I will review the test case information specifically. I know we have a lot of new adjunct faculty, just reviewing some of the information that the students should have, some of the requirements, and some of the kind of frequently asked questions that we came up even when we had our pre-calibration session yesterday. We had a lot of discussion about some of those things. And then we have some fun cases for you. So that's where those flashcards are going to come in. We're kind of doing it old school, so it's kind of very visual. So hopefully we get some audience participation. So this is actually, before we do the preclinical, this is from the CDCA. So this is the rubric. We're not going to go over it, but a lot of the criteria and the specifics that we use for our clinical restorative cases in the pre-clinic and in the clinic take the criteria straight from the CDCA.
I have an announcement here about CDCA. You can roll.
Yes, and Rodrigo is interrupting with his
Yeah.
announcement.
So we just got some dates for the CDCA bootcamp from start that we're going to do January 11th. It's always Wednesday morning from 9 to noon. So January 11, January 25, and February 8. We do need your help, please. I know Dr. Yamas is over there. So Peter just got those dates from Gisele. The clinic is going to be closed until 9, so we can join us at 9 o'clock. I'm going to send the announcement to Nikki. Nikki is going to share with the students. So please take a note. January 11, January 25, and February 8, 9 to noon in the same clinic. Thank you. Sorry.
Okay. All right. So CDCA, thank you, Rodrigo. You all can have access to the slides afterwards. So if you want to review the CDCA criteria and have it for you, just let us know and we will download it.
The slides and the recording link are going to be sent by tomorrow by Jack or Chris.
Okay, thank you. All right, so class 1. So this is the rubric for the class 1 as it is seen in pre-clinic. This is specifically, if you notice, for amalgam preparation. A majority of the preparations in D1 year are amalgam preparations, and there's a couple of reasons for that. We don't do as many up in clinic. However, on those plastic teeth.
They can't see the slides.
Oh.
Okay, yeah, what's share? It's not sharing anymore.
No.
No, it's
not.
okay.
So then,
Thanks, everyone. Hope you can see the slides again. Okay, so to go back, this is the amalgam preparation rubric as it's seen in the pre-clinic. They do a lot or most of their preparations in amalgam for a couple of reasons. It is a very technical, sensitive preparation. It develops their hand and eye coordination, their technical skills. They do a lot of measurements. You know, all the students come up to clinic and say, well, how deep is that supposed to be? And you really can't give them an answer. But simulating the caries on those plastic teeth can also be very difficult. But mastering those amalgam preparations, we can then take those preparations and alter them in the clinic once those concepts are kind of mastered. But what I wanted to draw your attention to was the evaluation criteria, and those are the finish of the walls and margins, retention, external outline form, and internal outline form. Those are the 4 basic criteria that are going to come up over and over and over again in all the restorative test cases and all the restorative assessments. Those are the 4 things, whether it be amalgam or composite, kind of break those things down. And the big things in each of those categories, the finish of the walls and margins, I'd like you to think about it as enamel. Is that enamel supported? Are the walls smooth? And then the internal angles, are they defined? So the big thing obviously is, you know, that's where I really get, was there unsupported enamel and how do we grade that? The next thing is retention, a little bit more relevant in those amalgam preparations. We still do assess that in composites. Students can do amalgams for their test cases up in the clinic on patients, just like they can do composites. But that category and that criteria is in all of the test case criteria. External outline form, that is, you know, obviously the external form. Is it overextended? Do we extend that? Is it too far extended buccolingually? The other big thing in this particular category is tooth damage to the adjacent teeth. So we talk a lot about that when we're assessing. Those are the categories in kind of the departments that those big things lie in. And then the internal outline form, specifically all the internal structures that have, we really think about that as adequate caries. So those are the 4 kind of breakdown criteria that we are using. And they are given that pre-clinic from, you know, the start of all of their restorative test cases. This is just a picture, for example, of what the ideal amalgam preparation could look like, the specifics that they're given. We're not really going to go over a whole lot of that, but this is straight from the lectures and the preclinical instructors that the students are being taught and the specifics. So if you want to know what they're being taught, as opposed to that when they get up to the clinic, you'll have those schematics for you. Same thing here. Obviously, this is an amalgam preparation, but in reference to their divergent walls and where they should be divergent and where they should be convergent. Okay, so that was quick through class 1. So class 2, so same thing. This is pre-clinic class 2, same rubric, a little bit more detail on the specifics of the numbers. That picture gives me anxiety, so I'm sure it gives the students anxiety. But if you want to know the specifics, the very detailed, what 2 millimeters, you know, where it has to be broken, all that kind of good stuff. That's what they're doing for their class 2s, where they're told to find the contacts. One of the big things I confirmed this with Andre yesterday is that buccolingual contacts need to be broken for amalgam. They do not need to be broken for composite, and that's straight from obviously the CDCA criteria. Cervical floor, that needs to be broken. So I did confirm that with her. The other thing, when we talk about with, you know, pre-clinic, they are not teaching them retention groups or composite slot preps. So I confirmed that, so, however, for amalgam, yes. Slot preps for composite, not for amalgam,
Those stay for composite.
and no dovetail for composite. So those were very straightforward specifics that I asked Andrea about yesterday. I got that correct, Andrea, okay, thumbs up from her. So questions about anything other than that, you'll have the slides, the criteria. Tooth separation, there at one point, you know, there was a question about if they can separate teeth with the fender wedges and the wedges and things like that. They are encouraged to do that down in free clinic, so if you do see them doing that in clinic, they are encouraged to do so. To protect those teeth, pre-wedge the teeth. We do not have fender wedges right now in the clinic, but they are encouraged to separate and protect the teeth in pre-clinic. And this is just the literature that, you know, supports that, you know, damage to adjacent teeth can be detrimental later on. So this is the slot preparation that is being taught with the very specifics. So if you want to know the specifics and the parameters for that, that's where that is. But again, no dovetail for those composite slot preparation unless indicated with carried on the occlusal, of course.
Okay, there is a question in the chat. So Jack, you want to monitor?
Yeah, I can do
Okay.
that. So Caroline asked, can these students do slot preps for amalgam?
So Andrea is saying, yes, they are being taught those for amalgam.
Yeah.
Yeah, but with the proper retention, you're teaching retention groups for those, correct, Andrea?
Yeah.
Okay. Thank you. Is that it?
Yeah.
Okay. All right, so on to caries removal. So this is what pre-clinic is for caries removal. We brought this up just for a lot of the definitions and terminology from the students. This is their rubric done in pre-clinic. We do not, as of now, have a caries removal test case. It's a restorative 720. I think we used to, but we don't anymore.
It's part of the test case.
It's part of the test case of the caries removal. So one of the big things, and I know Rita's here, is the caries removal at the DEJ. So that is one of those things that I think students sometimes argue with. But the DEJ has to be caries free. So we are teaching selective caries removal. So the periphery and the DEJ needs to be caries free and sound, but to protect the pulp, a minimal amount of caries can remain as long as we have an adequate seal and protecting the pulp. So we went over that yesterday. Rodrigo was nodding his head.
Yeah, from now on, we've got the slides that Margarita, Carlos, Mars, and the cardiology group share with the preclinical now, because they are doing some of the exercise in natural teeth and in plastic teeth to train for the boards.
So here are some of the articles where the recommendations came from. There will be in the slides. I printed it out and read them the other day, and they were really informative. It really had some guidelines in there of, you know, the guidelines of how much caries to remove, where the recommendations came from. The one big thing I wanted to touch on was the definitions. So when the students say it's soft, it's leathery, it's firm, it's hard, those are the definitions there on the right. The soft dentin, the leathery dentin, the firm, and the hard. So see, this is the next slide here. So there's the definition.
And we have a question.
Oh, sure.
And Dr. Migdal, he asked if caries extend to or beyond DEJ, are you then advocating on roofing beyond a slot prep?
Excuse me, is there a way that we can?
I
can't hear
did it
that
on the
here.
back.
We can't hear any. Oh. Fans are too loud, or you've got to get a microphone or something.
Yeah, there is no microphone here. We can just kind of. So question again, if from Dr. Migdal, if caries extends to or beyond the DEJ, are we advocating to on roofing beyond the slot prep? I'm assuming extending it beyond the.
Oh, sure. If the caries goes beyond on the occlusal surface, beyond the DEJ that requires a slot prep, put a dovetail in, yes, then the dovetail would be indicated. Hopefully that answered the question. Yes, Nikki.
Yeah, I just caveat to that in the context of symptoms and radiographic findings, right? And we selectively leaving caries
Correct.
in a localized area where if the expectation would be a carious exposure, correct? If the patient is asymptomatic and there are no contraindicating radiographic findings, right? Okay.
Correct.
Students often ask
Yeah.
that, they'll see a PRL and then they'll want to do the correct,
Yes.
okay, but I see what.
So with proper pulpal diagnosis, with a normal pulp, caries can be left over the pulp to not expose the pulp. Sealed off, yes. So pulp testing those deep carious lesions prior to caries removal, and obviously anesthesia would be indicated in this time. To hopefully get rid of it. Yes. That better? You can hear me more? Okay. Thank you. I know I'm going fast, but I want to get to the exercises. Okay, so this is just some pictures of the preclinical teeth, you know, caries excavation there, how they're taught with their burrs. Yeah, and then I think this is what you were alluding to, Nikki, that the spoon excavator caries tissue initially removed, sound outline form, and moving inward centrally, susceptible to leave the discolored, firm, leathery dent to protect the pulp. So again, using those definitions. Okay. Okay. I went through that really quickly, but any other questions about preclinical information? Andrea's here. She said that she's happy to answer any other questions.
That one question from Teresa in the chat.
Okay, so Dr. Short as test cases are supposed to prepare students for boards, do we accept incomplete caries removal on test cases, but let them know it could be a board failure if you left caries?
That's a good question. I think on the boards, it's still acceptable to leave that it carries over the pulp,
Yes.
as long as it is a sound periphery,
And then,
based on those recommendations. Carlos?
and then you announce to the examiners, you know, why you're leaving that is appropriate, but there's a clear risk of pulpal exposure.
Even like now they are doing the accidental teeth, so they are not supposed to challenge until have a corporate exposure. So if they start to remove, and again, is a flat teeth with different coloration, then it's with a very different tactile resistance for the tissue, but as soon as they get leathery to fur, they can claim that they are ready to restore. So Dr. Yema can make a comment on that with the new board system doing like in the mannequin, how that work. Pete, see if Pete can make a comment about the board's requirement for this.
So in the meantime, there is a question from a request from Carolyn. She thought that the caries removal sequence you passed a little bit too quick. If you could just come back and highlight the fact that
Sure.
I believe you are going to go back and use natural teeth to explain some of it, right? Because we do exercises with both natural teeth and plastic teeth.
Okay. So we've had a request from Carolyn to go through this a little bit more thoroughly, is that correct? Okay, or slower, I guess. Ron friendly, so, you know, just to go quick. All right, Carolyn, so this particular slide is showing a cross section of the tooth. What I really wanted to focus on were the definitions over on the right hand side, where it was the soft dentin, and then where we get into the demineralized leathery dentin, the firm dentin, and then the hard dentin. And that hard dentin is really what we see when we complete caries removal. And if Margarita and Carlos are here, if they want to jump in, you guys are the cariology experts, but all right. So, so when we do complete caries removal and get to that hard dentin, that is not what we're teaching the students anymore. We are teaching them to preserve the pulp in a healthy pulp that has tested normal, that is asymptomatic, that is acceptable to leave firm, even a small amount of leathery dent right over the pulp to protect that. And then the student needs to know how to manage that pulp, whether it be with a liner or some pulpal protectant, or how are we going to manage that prior to restoration? So those are the definitions that are being taught down in pre-clinic, where those students are bringing it to clinic. Yes,
Can I
Carlos?
make a small modification?
Yes,
The pulp doesn't need to be healthy. It's to be in a reversible.
reversible, thank you. Clarification, so
And in fact,
reversible,
if they are in the reversible tonsillitis stage, if you remove excessive amount of dent, you're going to aggravate that
right,
and probably lead into reversible tonsillitis.
right. Again, yes,
For what the discarded then, we need, student to remove it or just leave it if the dent is part.
so it's going about on a tactile sense, with that. Now, from what the tactile sense, Dr. Jen. So if it's firm, you don't need to remove it, even if it is right over the pulp, even if it is not, even if it has stain on it. But the periphery and the DEJ should be caries free.
So that means if some area there's a discolor, we need to remove.
No.
And if on the pulp, we need to save it. That correct?
That's how I understand it. Periphery and the DEJ. That needs to be free of stain and solids, but that directly over the pulp and the solids color within the.
I would say leathery or firm, but the soft
Yeah,
end
color-
in the red zone, that should go.
The color shouldn't be the criteria. The
Yes.
color
Yeah.
should be the criteria to use the tactile sensation. But the tactile sensation should be the determining factor to decide really.
If it's hard,
You can have tertiary.
This is, I think if you go back to the slide for a second, real quickly. The one thing that people, they want to see all the way to the right is soft, leathery, firm and hard. People see that like different categories, like it's really a continuum. So the idea here is that the periphery, the DEJ and all of that will be more in the lower side, in the firm to hard ending. When you're getting to the pulp, and then you are more tolerant to the higher categories.
Okay, I think that Dr. Yeman is connected now, and yeah, Rodrigo asked him for some clarification in regards to boards. Pete, can you share with us what you are doing in boards in terms of caries removal?
Yes, so I can give you the definition that the board uses, and we tell all the candidates before the exam even starts. The definition that is used for the caries is that with a minimal pressure, it has to have tug back and it has to have penetration with an explorer. Otherwise, according to our criteria, it's not evaluated as caries. And the DEJ does not have to be stain free. As long as it's firm, there can be stain on the DEJ. It's not necessary to have a clean DEJ as long as there's no penetration with minimal pressure. So that's kind of the criteria that the testing agency uses for determining caries.
Terrific. Thank you, Pete. So there was a point also from Caroline about the instrumentation. If you could just very briefly say what's been taught in the clinic in terms of instrumentation.
the instrumentation for
caries
caries
removal.
removal.
We have, I think, those slides that go start with the 330.
Oh,
change, yeah.
Correct.
You can advance, I think she's.
I can advance, okay, so here are the definitions again, so hopefully. Okay, this is probably where she was talking about the instrumentation, okay,
I
so,
think you have we open the main one with 5 or 330, and then we use carries in the first, we are ground lights
okay,
for carries.
okay,
And we finish everything with a spoon excavator when it's closer to your pulp, or when we have something we refine adjustments should.
Okay.
Maybe you should repeat.
I'm
Can you
going to
repeat
repeat
that?
that. So, of course, thank you, Andrea. Andrea clarified that. So initial entry is made with a 3:30 or a 2:45, just as in this picture. And I realized I skipped through that pretty fast. Then the access to the curious lesion is with round carbide on a slow speed. And then as you get nearer to the pulp, a spoon excavator is done for that final curious removal. So that is what they're being taught in frequent, correct, Andrea?
Yes.
Okay.
How can the students be instructed to treat the remaining areas over the pole for places of respiration? I just want to know what they're being taught.
So you're asking what action?
Right, when you're leaving areas, leathers or.
So if Paris is not shooting, they are just taught the seal is the deal, seal very well, make sure that you're seeing everything, so there's a direction, there's a oxygen substrate. Right? Which if there is necessary to use a liner or a base, then proceed according to the case. For example, there is direct, the need for direct home capping, happening, it's indirect capping.
So what I'm still not clear on, obviously, if we're leaving areas so that we don't get a focal exposure, by definition, we are deep. How are we treating that?
I can tell you what the research shows. The research clearly shows that you actually don't need any indirect contact with you as different materials. They all perform the same way as long as you have an effective respiration and filling the margins of that respiration. So the reality is that they don't need to put anything. Many of our students, because they're not technique savvy yet, many times what they will try to do is put a base on flat ionomers and get a feel there and then construct the rest. But if you look at the research, it doesn't matter as long as you get a good feel. You will get tertiary then form, and if you open that up 8 months later, it will be drier and firmer, regardless of the base.
Andrea, what are you telling them to use for a pulp cap?
So they learn how to use Dicot because this is what we have in our clinics, and they learn how to use full time.
Kotek fill or glass ionomer liner?
Sorry,
Okay.
glass ionomer on top of the Dicot and full tactile as well as a base.
Okay, so typically for a direct pulp cap is the dical with the glass ionomer liner over the dical, and for an indirect pulp cap, they'll be using a glass ionomer liner right over that carries that flat. So hopefully that answered your question about what they're being
So my
taught.
last probe on that is, again, we've got remaining carries, leather for over the pole, but we took it out, we have a potential exposure. So before we go and place it in the deposit, is there, so are we sealing this and purposely covering that area so that when we place our acid etch for a composite, we're not getting acid etch into that deep focal area?
Yeah.
I personally recommend to put a glass number to seal the area. However, when you look at clinical trials, companies that just use composite without doing it, that would be going to struggle with this. Theoretically, glass number makes more sense. This is what I do personally. And I do the composite without that. When you look, I'm going to show you the data that actually perform better than the other one. I can show you.
So it's not important for me. My question still is like, what are they being taught? So I know what to expect.
Yeah.
I don't care. You can cite the research. I don't care what it said at this point, because we are developing the curriculum of what they're being taught. And we're trying to establish a continuity amongst all of us. That's why I'm hammering on this so diligently. I want to know, because you said personally, right?
Correct.
You didn't say,
Because I don't.
this is what we're teaching.
Yeah, yeah.
You said personally. I want to know, what are we teaching? So I know where to set my expectations.
We are teaching for having direct exposure, we are going to use Dicot and similar with the GI and we will see. If you don't have a direct exposure, it just goes with just GI and then that's the exposure.
Can you
Yeah,
repeat
I'm
that
going to
because
repeat
people are having a hard time
Yeah,
listening?
for those of you on Zoom, so the question was, what are we teaching the students? Specifically about when we're leaving caries close to the pulp, what is the protocol for the students specifically, that we all should abide by? If it is deep, and you're doing a direct pulp cap, they're being taught to put dical and glass ionomer over the dical. If it is not a direct pulp cap, it's an indirect pulp cap, it is okay just to put a layer of the glass ionomer over that deep part of the pulp prior to etching and then putting your composite. Okay, so that was clear, so hopefully,
Can I ask a quick question about this? In the
Yeah.
clinic, are there any other options? Are the MTA, for example, available or?
Sometimes, so in the clinic, when they are working and they are like in the rotation, few of the students, they go, they get some biodenting and they use as an option. So, but we don't really care that in the clinic, but the students make that happen going to endo. And I saw some of them, you look to the nose, and when did you get biodent? Oh, I was working endo. They said we can come here and use biodenting.
So we
my
teach MTA and we teach biodenting as well, but we don't have it, that's why we emphasize the.
But I think it's a good place to communicate that, so they understand that what is
They
available.
know MTA is, they put that biodenting is, and don't have it.
There is not, so what is taught about,
We can teach that to medical, sorry.
so you're not teaching Luma at all.
Okay, similar. We
Okay,
can start
not
if you
similar.
guys
well,
want.
it's in the materials, it's actually materials manual, it's there.
Yeah.
Available for you, so I didn't know, but many of the students are not. Know if that was the reason.
We could, it's just.
Do you have a question?
Yeah, recently I have a student place the liner, GI liner, and then they just put the smearly, or it's everywhere. And when I asked them, why do you put liner? And so that, how much? They said they are not taught in the pre-clinic, how much, or where it's like. I just want to make sure it is.
I'm gonna repeat that question. So Dee had a question, and I actually was working with Dee this morning in clinic and we were talking about it. Is that the placement of the liner? A lot of the students, say that they're not taught maybe placement of that liner. So maybe Andrea, can you comment
So
on?
we do in the
on
last
that.
2 years that I'm doing that, we teach them, they have a practical part on that, but before that, I don't know if it's a D3 or a D4. I was not there, so I don't know where, what's the, they learn. So, but now they do learn to how to use and they replace in many different occasions, so they learn the amount and the technique.
So we want to these three before we know them.
I'm not sure if they did that, to say that.
Any more questions?
Yeah, so there is a couple here. One is from Dr. Migdal. Again, it's kind of long, I'm gonna read it. I'm finding that students seem to be favoring a conservative prep rather than unroofing the decay for visibility, etc. And this seems to be leading them to create some unnecessary pulp exposures. Is it possible that we are failing to let them know when certain radiographic images dictate a less conservative approach results in better outcome? Clarifying my previous comment. Caries going axially without being evident from occlusal. Do you view this as a condition to prep more than a conservative slot?
I don't know if I understand the question.
I didn't understand.
I understand.
Okay.
Do you understand?
So what he's saying is that when you drop a slot prep and you can see the caries going axially, do you just take your burr and keep going underneath your pulpal floor? Or do you unroof that pulpal, the floor of your prep? Yes, you unroof the floor of the prep because you have to visualize it again, because you don't know if it extends onto the walls as well. So they are being taught to remove that for visibility.
Yeah, just an addition to that, remember the first step is caries removal. And once the caries are gone, then you look at the remaining tooth structure and decide, how can I make this into an appropriate prep for the material that was chosen? Or do I need to choose a different material? So the first step is caries removal, convenience form to remove the caries, and then look for undermined enamel and supported enamel and all that to make it proper.
Exactly. And going back to the Bluma, they do learn what Bluma means, and but they don't have the practical exercise. But we have the
So there is one point here from Dr. Wayne Walker, and I think that we need to clarify this. The question is, if adjuncts come from private practice, they are not comfortable with leaving caries soft denting, no retention, etc., especially if the students are operating on their license. It really, when somebody comes from the private practice to the school to teach here, we need to follow the guidelines that are placed in place by the school. So that is something that I think it needs to be very, very clear. Whatever the students are being taught here, that's what we need to teach them. Can you just expand a little bit more on that?
Sure.
Or Rodrigo or anyone. Because otherwise each one of us will teach a different thing. And so then calibration is for no use.
I can maybe expand a little bit on this. Because I agree with that 100%. Sometimes there are more than one methods, more techniques, more than one material to address the problem. But at the school level, in these conversations here and the course directors, discipline coordinator, they need to make decision what is going to be taught to the student first, what is going to be used in the clinic for our learners. So we need to be on board. You may be in your practice, I don't know, you prefer to use a matrix system that we don't have here. But here we decided to use one, and then we are teaching the students to do that. We cannot allow every faculty, clinical faculty, to choose on their own whatever they want to teach. This is the place to discuss the evidence, to discuss the technique, to say, you know, I have enough evidence of a good rationale why we should switch from this to that, and that's perfectly fine. I think it's perfectly fair to do it in these calibration or training sessions that we have. But I think we should be all on board. This is the time to discuss and bring your expertise, your ideas, and discuss that. I sometimes don't agree with everything, but I go on board. We need to go as a team.
Anything else? There's Spangley.
I think I would like to point out that, again, if we're not going to be consistent with the board, then we need to point out to students that we're not being consistent with the board. It's not fair to them.
Sorry, Craig, but we're consistent with the board. What are you saying? We
Because-
just said,
Because on the board,
we come and just say that how they do, which is exactly the
Yeah.
word.
but if I take a look at it, when I see tug back, and that's caries, I could see tug back here and it would be okay. On the board, that's going to be a failure. Tug back here might be acceptable to leave in.
He didn't see.
Okay, well then, I watched the calibration video last night. I'm an examiner myself. Calibration, the 2022 calibration video said if you have tug back, that is considered to be caries left in. So I'm fine with teaching. I'm fine with teaching other things, but you got to be consistent with the students, so letting them know when it comes time for the board exam, that's the board standard.
Maybe Dr. Yeman, can you clarify again the criteria for caries removal for the board? Because
Yes,
we
I
have
mean,
a divergence here.
Yeah, it's basically what was just mentioned. Like I said, the definition that is used by CDCA is minimal pressure. And they really mean minimal pressure, not really pushing down real hard on Explorer, and then getting tug back and penetration. If those things exist, then that's evaluated as caries for the exam.
Well,
Yes, it was plastic too.
yeah, well, and I think we know we don't necessarily teach some things to the board. Because we teach based on evidence, and and we do make the students aware that if you are in a board situation, you're gonna have to be more aggressive than you would probably be in other settings, but based on the evidence, this is what we're teaching students.
And
And they are told that.
I appreciate that, but I thought, to quote Carlos, we're trying to come up with consistency. And the clinics, we're trying to figure out what they're being taught in pre-clinic, because we are still trying to find it. All right, so again, I'm all for consistency, but what I'm hearing tonight is not consistency among this group.
Well, that's the reason for this meeting.
Okay,
right?
I'm good till midnight. How long do you want to go?
And remember, those are plastic type of
Right.
humans, so there could be some consistency between those two, but we have boot camps. And Rodrigo just announced, we're having these boot camps so that the students can learn in context of type it out to what the board is expecting. And yes, it may be different than what we expect in the actual team. Unfortunately.
Yeah.
So in the clinic, we don't teach to the board necessarily that prescriptive, but in the boot camps, we do.
Thank you, Nikki. All right, we are gonna move on. Is everybody comfortable with or the caries removal criteria, the definitions,
Yeah.
and the pulp cap procedures of what the students are being taught and what's acceptable in the clinic? Okay, thank you. Okay, so as far as restorative test cases, we're talking about specifically the class 1 and class 2 is 720 and 820. This is what the students have as far as this is the general guidelines. So I think we've all reviewed these. I think we've all come across students that don't have these up. So a couple kind of just helpful suggestions as we are doing our test cases up in the clinics is that one, make sure that the student has this criteria pulled up. So that's the one first thing I have is that, did you pull up the criteria and did you read them? I can't tell you how many times that the students say, oh, it's a non-vital tooth. I says, well, it's right on the criteria. You know, this shouldn't have been even called for a test case. Make sure you have that criteria when the, or make sure the student has that criteria when you come over. The next thing is the time limit. I know Rodrigo sent out an announcement about the time limit. A lot of the students are starting later and later in clinic. That's one of my biggest pet peeves, especially at 9 o'clock. You know, they're getting their patients at 9:30, they need to be done on time. If their patient is late, you know, and they want to do that test case, well, they have to decide if they have enough time to do so, that they don't get all of the time in the world to do that test case. They have to be done at 11:45. So there's 2 hours and 45 minutes right now, only for the next 2 weeks when we have clinic from 1 to 5. That time frame is 3:45. It will extend to 4:45 when we start clinic at 2 o'clock in the new year. So I know a lot of students, you know, are upset when they fail because their time limit, but kindly remind them at the beginning.
Isn't part of the exam for the students to know what the criteria are? Why do we have to tell them?
I have no idea.
I mean, they should understand it. They
You
don't-
are correct.
If they don't understand the criteria, that's it.
That is correct. And it feels that, you know, there's a lot of times that we will say that's not a good test case and, you know, we should decide as well, how strict are we going to be that, you know, that students should know, hey, you know, do you let them take that test case and say, hey, that was a failure, that was a poor case selection? I think that there is, you know,
In
a lot of
terms
discussion on that.
Sorry for that. In terms of a test case, in the beginning, the student decided to do the test case, but in the middle, in the student, oh no, I just do the regular, I don't do the test case. So
Yeah.
how to deal with that, you know, situation?
Yeah, so Dr. Jin's question was, how do we deal with the situation where you've approved, you know, you've assigned the test case, to faculty have said, yes, go ahead. And then in the middle, you get called over and maybe you look and that patient doesn't have a rubber dam on and you said, what, you know, I thought we were doing a test case, there's no rubber dam on. Oh yeah, I decided not to do the test case, you know, it was too hard, or I couldn't get the rubber dam on, and that student has not informed you. You know, in my eyes, if I've assigned it and we've decided to go ahead with the test case and you have not followed through, that's a failure. That's a failure on the student's part.
And touching base about the rubber dam isolation, I hope we're gonna be for all the procedure, but test case
the preparation part is supposed to be done by the isolation. Nikki had some students inquire, some faculty say, no need to prepare with the rubber dam. If you look at the rubber, the test case should be done under rubber dam isolation.
Yes. So that is required. The other thing that we talked about in our pre-calibration was, let's say the tooth has caries on the medial and the distal. And they are required to do either for their test case. And the student says, I'm only gonna do the DO portion today, and I'll save the MO portion for a later date. So it's one of those things that the whole entire tooth needs to be treated, that tooth is being numbed up. But we needed, that student should know that identify the caries properly on the entire tooth, have a plan for the entire restoration. So if it's a DO and there's a separate buccal caries, that should be addressed as far as the test case. DO portion can be graded as the test case, but the entire tooth needs to be treated and restored. So, you know, there's been cases where I've gone over and the patient or the student has prepared just the DO. And he says, well, you know, what about the caries that's left here? Because we have not properly, you know, restored or prepared the tooth. Oh, I'm gonna do that at a later date. So that's one of those things too, that, you know, making sure that that student has a proper plan for the entire tooth. Yes.
Dr. Short, I have a question here about the enforcing patient and case selection. How much should we enforce case and patient selection?
That's a really good question. I think that we have a lot of discussion about that as well. You know, I think some, you know, Nikki and I had an example, I think we brought up at the last calibration, that the patient was really adamant about the rubber dam and was very anxious. We decided it wasn't a great case selection, and we did not punish the student because it was a patient determinant at that point. However, you know, for case selection, you know, you get those that are occlusal caries that, you know, the student really thinks it's just a little bit, and it's one of those big monsters when you unroof it, which is really kind of a poor case selection. Do we let them know, or do we struggle? And that's a really good question, and I'd like to hear everybody else's thoughts on that. I'm kind of understand that, you know, we never know what we're gonna get, and you know, that's part of the student's test case, is to be able to manage unexpected things that may arise. Yeah, Carlos.
I have struggled with that for a long time, for at least 15 years or more. Because they come to you, they say, I'm gonna want to do this test, is this a good case? They show you the radiograph, stuff like that. And to me, that should be an automatic failure, because part of this, what we're testing is diagnosis, right?
Right.
Are you able to diagnose and determine this is the appropriate treatment plan? However, we never done it. It's I never fail anybody because of that, even though that's what the way it felt.
Right.
So I don't know, but I would be very much in favor. I mean, because we focus so much in the technique of the caries removal and the preparation of the restoration, that we forget about, are we really treating the tooth that needs to be treated, for example?
And we get a lot of, hey, I want to do a test case today, which one do you think I should do? And, you know, that's, you know, coaching the student, well, that's part of the test case, and you being able to diagnose and prepare the treatment and then render the treatment.
For a practical question, on the criteria, an opposing to that's being treated. Does the restoration have to have an opposing contact, or just an opposing to the present?
Can you repeat?
Yeah, Nancy's question was if you're, for example, like a class 1 test case, so
Or interproximal, maybe there's only contact on the distal margin, but they want to restore the mesial.
correct. So, for example, the class 1 test case criteria says that you need to restore the occlusal contact. But her question was, what if that tooth has an opposing tooth, but you're not restoring the contact with the restoration, but the tooth has contact maybe on a different part of the tooth, like the mesial marginal bridge? From what I understand, as long as that tooth has opposing dentition, that is okay and meets the criteria for the test case.
Okay, yes.
The criteria is not so specific regarding to the opposing contact in the restoration.
Correct. The tooth has to have an opposing tooth. It came up one time too, that the patient was wearing a denture. You know, I took that as that the patient has opposing occlusion, it wasn't a natural tooth. But that student did demonstrate that they could properly restore occlusal contact opposing a tooth, whether it be natural or a denture.
So Brand is just asking for a clarification here, and I think it's a very good question. To be clear, if tooth number 3 needs an MO restoration and a separate DO restoration, and the student is test casing the MO only, do they need to restore the DO in the same visit, or just have a plan to restore in the next visit?
The same visit. I think that was the consensus that we had, that the tooth, what you would normally do for patient treatment that day, to be finished. And that's
Dr.
the proper patient management, really.
Dr. Karpenko, can you hear me?
Yes,
This is Brent Fold.
hello.
Thanks. Thanks for answering that question. The reason I ask is because that seems inconsistent with what a student might do in a typical clinical session, especially if we're allowing them to do slot preps. Based on the student's ability and the time of the appointment, they may only have time to do an MO on 3, and we decide that we're going to do the DO a different day because they just couldn't get it done. So I just want to clarify, on a test case situation, they have to restore that whole tooth.
Rodrigo as discipline coordinator is nodding yes.
Okay.
I'm not like this, and I'm not treating a test case, I'm treating a human being, and then the most dangerous part of my appointment is I need to get my patient on. I'm gonna get my patient on for an MO, bring him back, get him on again, do a TO. I don't think that big, like if you're a healthcare provider, you're not delivering care, you would say, I passed the test case here, come back, I'm gonna get you number again. In my mind, it doesn't make sense. So that's why we discussed yesterday, but I'm open for suggestions. What do you guys think?
I understand that doesn't make sense. I agree, it doesn't necessarily make sense. But it happens every day in the clinic and on the boards. That same situation on a board exam, the student would not have to do the DO portion. They would only be test cased on the MO. Please correct me if I'm wrong on that, but I just want to make sure.
That's not true.
Okay,
That's not true. On the board with the patient, on the posterior tooth, they have to treat the whole tooth.
okay, thank you.
But since we're now doing mostly typing on teeth, that doesn't really, that's not a problem anymore.
Oh, I got you. Thank you.
Right. Thank you for that clarification.
Thank you, Dr. Yeaman.
Yeah, that was a good question, Brent. Thank you.
Therese has her hand up. Therese. Go
Can
ahead.
you hear me?
Yeah.
Just on what we had talked about before and everybody was kind of giving their opinion, can we ask the department leadership or whoever to decide how you want us to handle patient selection and case selection? Because if we're given a directive that if it's poor and, you know, then that ends up being a failure, we're all in the same guide here, because otherwise you have some faculty adjuncts that are like, well, yeah, we'll just forget about this one. And then others that are failing. And I have been chased down for failing a student before. So I'd like to know what the consensus is, you know, even if it's not decided tonight, can you do that? And then kind of let us all know.
I think this is a easy one. I think, as Carly said, this is part of the diagnosis. This is part of the appointment. If they don't know how to select to diagnose a case, is a failure. I'm sorry, it is a failure. This is my thought. I don't know what you might think. You're gonna give like a guidance. Oh, you know what? I think you need to do this and this and this. So this is not a test case. They are not like driving the family. They are asking you some feedback during a test case. You can give feedback, but I say, okay, you fail. Let's move on. And you fail because of this, this, and this. This is part of the test case that I understand.
I agree. And I think that it takes away the preparation. There's nothing wrong with a student asking before they pick a test case to show a faculty prior an x-ray or anything like that, you know, prior to the appointment. But during, you know, to come to the appointment and say, I think I'm going to do this as a test case. And then it's like, oh, maybe this isn't a good one. It just seems unprepared.
So Dr. Bozell says, should the grading criteria include case selection?
It's part of it.
It is there.
It is.
It's part,
So that tells you all.
it's part.
So Rodrigo, what are you saying is that, you know, if the faculty decide it's not a good test case and that student says, hey, I'm gonna do a test case, and two faculty come over and say, I don't think that that's a great test case, or you can pick a different one. You think that that should be a failure?
I think that should be in that criteria. A V, if they have a V, it's a failure. If you have the criteria, case selection, and you select the wrong one based on your judgment, your diagnosis, you got a V.
So that, I think that that is, you know, I mean, Teresa is right, that that is not a consistency that I see in the clinic. So I think that there has to be a little bit more guidelines on how we're going to decide that that is a failure. And you're right, we may have to talk about that, revisit that. Next calibrations.
I think it's difficult to enforce, so having a
I agree.
very thought out plan is important.
Okay.
Because there are many ways around it.
Right, I think that's a great point, and that's something that, you know, a group of us can discuss, Teresa, and I'd be really interested to hear your thoughts as well, so I might be reaching out with that.
My concern is this, and I realize this is a difficult question, but I had two D3s today, two surface composite test cases on my test kits that were barely, that were just enough caries to make it a test case. One of them took 2.5 hours, the other one took 2 hours and 46. If there would have been another lesion, let's say on the distal tattoo, there's no way to do that. So are we assuming there's an overabundance of patients that have qualifying lesions for test case that the students have access to, that we can afford to limit them to what teeth can be done? Because in this case, they couldn't get done with two surface, let alone two surfaces in the alignment.
Yeah, I just think every time that I see a patient, I put myself in the patient position. You got a patient coming to the school, just got down, and you have that done. Can you imagine you drive 2 hours to do it and say, okay, now you come back because I need to go and address something else. I don't know if I can call that good practice or best practice. So probably that too, maybe if the student cannot do like a small TO in 2 hours, I can understand that the D3 with the half of like middle of the semester, they should like speed it up to be able to deliver care in an appropriate manner for that patient. And I know some people are laughing, but this is I think what I think and what I believe as delivering health for a patient. Test case is secondary. Patient care is what we are looking for. When people are so concerned about the boards, we don't teach the students to pass the board. If you have a good students, they want to challenge the boards, they want to pass it. I know.
So I rationally, I agree with everything you said. Reality, that's not it.
Yeah, so I can tell you, you can teach the students whatever you want to teach. If you put together a 4-month course every single week, like a boot camp, every single student going to pass the board. Is that the mission of the dental school, pass the boards? Or no? I'm asking you guys.
You're asking me.
Yeah. Are you think is our mission to?
That's not the total mission. Does it have to be part of it? Yes, because otherwise we have to practice.
Yeah, but you think if you're a good student, you're gonna challenge the boards, you're gonna pass or no?
They should absolutely pass. We're doing our job.
So if you do like high level density from D1 to D4, you're gonna challenge the board, say, don't worry, you're gonna pass. You're gonna pass. I know schools now, because I keep like touching base with students, say, how many failures you have in that school? And they have like 2 failures. I say, what you guys are doing is magic. You know what they're doing? They are doing exactly what I said to you. 6 months boot camp every week to prepare the students for the board. So then I came to Carl and said, do you think this is create a course, CDCA preparation? There is a space in our curriculum to do that. Or you can revisit our mission and say, this is what is important.
No, absolutely no. And not only that, I don't think that should be the mission of the school. I mean, obviously we want them to pass.
Yes.
But we are hopefully looking much higher than that.
I just want to make it clear that two sides of that coin are, we want them to be fast enough that they can do the demo and the deal at the same time. Reality of where we are, I had it approved it today, 2 consecutive cases. So what I'm saying is if we want to enforce that, which I'm okay, if that's what we agreed on, but we realize it's going to make the patient selection book available for the students much smaller, because they are going to have to singularly look for a single lesion on a tooth, and they know they won't get the MOD done, but just to be done.
And I think the other point to follow up here is in clinic, especially with our 4-hour sessions that we have, students will take as long as they possibly have to do it. They could do it faster, probably, but they will take as long as they've got. So in reality, we've actually potentiated that by having the 4-hour clinic session. That's reality.
So I don't have a good answer to, I don't know if you have.
I do not.
I do believe it's to these two one saying that it's base tracks, whatever they have. But one thing that is relatively new is that students are taking space. Because they have more experiences before they would take them, so they will learn faster than they would have. Hopefully, hopefully that getting back to that. I don't know. I think it's a very fair concern. Do we have enough basis for that or not? But I do believe the students adjust to these certain degree, and I think they will go faster than we think right now. They're taking right now 3 hours to do one small MO and under B, sure. But if you give them maybe 1 hour, they might do it as well. So they might, but I know, I think it's a very concern.
Okay, we're ready to move on? Okay, let's go. Audience participation. Okay, so we are gonna go through those criteria that we talked about, finish, walls that we talked about, retention, internal outline, external outline. So we have some cases for all of us to look at. Rodrigo is going to want to poll for those of you at home. For those of you here in the audience, we're kind of going old school, so you should have a set of flashcards, so you don't have to log into anything. So we're just going to talk about some cases. We're not going to assess all of the criteria on all the cases. We picked out specific, whether it's internal outline, finish, we'll let you know what that may be. So on your flashcards, R is green, so it's green is go. B is red, so that's stop. S is like, it's okay, that's purple, and T is like orange, is like, it's getting to that stop zone. If you don't want to hold your card up, that's okay, but we're hoping that we can flash, the case up, everybody can visually see if we're calibrated, see if we're kind of in the zone. If we've got a few people that, just aren't understanding what other people are seeing, we can have a discussion about it. And on the Zoom poll, it is strictly RSTV. That's all you gotta put in. Okay, so we talked about that. So this is the first one. A group of us did these yesterday and pre-calibrated ourselves and talked about a lot of them. But this one specifically is the finish of the walls and margins. And to Andrea's point, we had some notes about this one. This one, we had a couple questions. You are going to assume that nothing is unsupported, correct, Andrea? She had a little question with the angles and the photos, we couldn't quite see. So the enamel under this kind of ridge over here, that is not unsupported.
Correct.
And this is a composite crack, correct?
And we are judging only margins.
Yeah,
Finish of the walls,
we have another criteria come up.
okay?
Okay,
Alright,
so
we're
I
ready.
think the poll people already did some response online and then we need
Okay.
to check here.
Okay, so we've got green and purple, good,
Most of them, yeah,
all right. Anybody that gave a S or a purple, that was just, maybe you can comment on what do you see and what do you feel that could be modified? Anybody that wanna volunteer?
Gave a purple. What is wrong?
I gave a purple.
I didn't like the bubble variant.
Okay, Dr. Spangler didn't love the bubbler. What would you suggest that would be modified?
I think that even the preparation needs to move out more, but I also see a little bit of some stain in there that I don't like either, but I would actually try to make that crisper and margin in that area.
So you're gonna challenge and stain until you remove all the stain?
Not necessarily, because we're only creating the margins there.
Yeah, so the margin, so
Yeah.
what you see stain is like an internal outline.
Yeah, so I'm looking at it and saying that I would make that margin crisper in terms of the margin itself.
I think that's correct, right? And the staining is, connected to the outside. That's my concern.
Okay,
If you do the, composite, that's it's not good.
Dr. Bid,
So I think if we're talking about the criteria, specifically the finish of the walls, the only place that it's slightly rough would be on the distal lingual. Just slightly rough there. Because we're assuming no unsupported enamel,
yep,
and we're only talking about the finish of the walls, right?
talk about the finish of the walls and margin.
So
So,
just as you come around in that area, that's where I knocked it down.
good. Anyone else?
Can I be the devil's advocate?
Yes.
Why do you want to have a smooth wall for a composite restoration?
You don't want any sharp angles to concentrate forces. And that's an illustration. You have a better notation.
Yeah. In the margin of the composite, pretty much. And again, we're gonna use those sessions, and I hope you guys can look to the criteria that we have now. And we are open to suggestions. We need to update them. We agree on. Some of them, we are, even like the points, we just changed some points because we got some kind of, when you do the maps, T and S, they are very similar in some of the test cases, we changed that. So we are open, we are trying to move and review and make like necessary change as you guys think is necessary, and we agree. Okay, now, we're moving now like this. You messed up, go.
How do I get it? How do I do it?
Yes, there we go. Yeah, you can,
Okay.
this next.
Okay, all right, so this is the next poll. This is the same picture. Okay, same preparation, but a different criteria. This is the external outline that's done. So the extension on the external outline. All right, did you launch the poll?
Steve, as I told you, you cannot be loud. Now, it's just, I told you, but it's okay.
All right. Well, Rodrigo's launching the poll for those in Zoom. How about those in the room? Ready? External outline. We've got some oranges.
1 second, guys, online.
We've got orange, green, and purple. Right. I'm gonna pick on somebody who held up an orange, a T.
I think it's overextended.
It's overextended, okay?
Can't handle it. You messed up.
Does anybody else agree that it's overextended for the amount of carries? Dr. Heiss? Okay, so that's moderately overextended, so that would be a T. Anybody else disagree?
I gave an S, but
Okay.
I also think it's a.
Good. So from the start prep until what the student has shown you here, you can see that that would be moderately overextended.
Okay, I just realized here, I cannot do from that.
Okay.
Okay, let's see, you guys online, I think are gonna be able to answer now, there we go.
Yep, so. What the online say. All right, so mostly S's there, so. No B's, but mostly S's. So we're getting into that S and B category, so that's kind of where we get the most. All right, let's move on. Everybody okay moving on? All right. All right, so this is the finish of the walls and margins again. So we had a,
I don't know what you did over there.
I didn't do anything.
Okay, good.
Again, we had a little discussion yesterday about this little spicule here, if it's unsupported or not supported, we can't tell with the angle. So for now, we're gonna assume that that is supported and not completely unsupported. We're not quite sure. All right,
We're judging finished walls and margins.
we're judging the finished walls and margins.
And there is no one.
Yep, ready? Purple, couple greens. Purple. Did you do the online?
Yes, we still going.
Oh,
We have 11. Well, we're still going. That points, this is what we got.
okay, so a lot of majority of purples out there, or S's, I should say, so. Who gave it an S? Anyone that want to comment? Nancy?
It just looked generally rough.
Generally rough, okay, so it was okay, but not perfect. Okay. Good. Want to do the next one?
How about?
All right, so this is the same picture again, but again, the external outline, so different criteria.
What's the size? What's the size we should assume that's a little?
That's a good question. So Andrea wants to know the size of the little spicule right there. That is less than 1 millimeter.
And this is for composite.
This is for composite.
Yep.
Ready? Go. All right, so I've seen some greens, some purples, a few oranges. Any V's?
No beads.
No V's. Okay, so everybody agrees that that's not a major error. Anybody that thinks that that's perfectly fine and that would be clinically acceptable? Dr. Heiss? Okay. Majority, what does the online people think?
Online majority is 42%. There's a tie in S and T.
So I think that was pretty consistent to what we had in the room, so. Might be a situation that you talked about faculty members and decide, but nobody gave a B. Good. All right, Rodrigo, what's next? All right, so this one was again, the finish of the walls and margins. We're gonna go back to that. So finish, as you can see, there's a couple different preps here. There's a little spicule here or a little divot there. But from the picture on the left is the start check, and this is what the student came to you and said, I am ready to fill. Okay, you're launching the poll already, go. Dr. Jen, can I single you out for a minute? So you had a T raised.
I just want to, raise one question.
Yeah.
In that is the medial or distal, the range margin. That is, an unsupported enamel.
Okay.
Yes, there is, there's an enamel shell. So in that case, for, the composite, if you go to the board exam, maybe that is not, and it's fair, right? It's failure. So, but in our, test case, how do judge it? That is my question. Another thing, if do for the regular, the clinic, the practice, I think it's okay. We just do the, the composite.
Okay.
So that's, is That's my question. So
So
that's
your,
why,
your concern or your question was this ridge here unsupported and too close to the margin of ridge where that would result in failure because it was too thin?
yeah,
Let's for a conversation say that was a good 2 millimeters and we're not concerned with that being too thin.
so that means, for, in that case, that we don't consider that is unsupported animal.
We're not gonna consider that unsupported now.
Okay.
That's a good question. Anybody else?
Here's online, we have a type R and S, then 1B.
1B, okay. Anybody in Zoom want to comment? Anything other than an R and an S, their concerns are? All right, if not, we'll move on. Go ahead, Rodrigo.
One external line.
Okay, so again, consistent, I'm sorry. Oh, Teresa has a question. Or a comment.
I have a suggestion for doing these, because obviously even just doing it like this, you're getting 2 and 3 different responses, so inconsistency. If, when you're showing these or when you do these, I think it would be great if you show us the unprepped tooth, then prepare it as you would expect a student to do their ideal prep before they ask for extension. If we treat every test case like we treat everything like a test case, I think we get more calibration. Does that make sense? Like, you'd prep it, show me ideal, then you're gonna ask me for extension. Then we know, like, did they overextend? How, it's hard for us to look at this and go, well, I think that's overextension, but how do I know? I don't know when they opened those grooves, how far, the DEJ, the stain on the DEJ was.
Right.
It'd be kind of nice to do ideal prep first and then show why you're extending, and then we would know, like, okay, that's overextended. To show us what would be right.
Right. That's a helpful suggestion. We do have a couple photos like that coming up, Trace, where we have some steps. These are the photos that we have with those preps, but for conversation's sake, we are going to assume that this is what the student presented with after the start check, and did not ask for an extension. So we'll try to get some of those in between photos for next time. We do have a few of those in there. Hopefully that helps.
Okay, now we have to find a way to external outline. Right?
Okay, yep, thanks, Andrea. External outline. And that does bring the point in when we were discussing this yesterday. Okay, ready? Go. Good. So there's a lot of teeth. Dr. Spangler, I'm gonna single you out. Why do we give a T?
I think it's overextended.
Okay, so to Teresa's point, from the beginning of the start check to this is what the student presented without an extension, this would be considered overextended. Now, if the student in between there had asked for the extension and ended up with this particular preparation, because the caries went there, we would probably not consider that overextended on the external outline. Good. All right, let's move on. Okay, so we had a lot of fun discussing this one. Andrea, I can't remember what we decided. Oh, I know what we decided. So what to this point was that the student got the okay in the start check for we're gonna call that the MO, okay? And we noticed that they said they were gonna address the caries toward either I think that's the distal pit. I'm gonna call that the distal pit for conversation's sake. That's the MO box. So from the start check on the left to what you see on the right hand side, no extensions were asked for, and that's what the student presented with. So you can see that they prepped a little additional right in the central pit area and those other two little I'm gonna call them quasi preps, you know, the quasi prep in the box. So the first category is we're gonna look at the finish of the walls and margins again. So we're going to assess that. So. We ready?
Yeah.
Go. Okay. Couple TVs. Margarita, you gave an R.
Was me.
Oh, Carlos, I'm sorry. I called you out. I called your husband out. Carlos, you gave an R. So that was a finish of the walls and margins. Andrea, you had a V up.
The student prepped an area that I didn't authorize him to prep.
But does that go into the finish of the walls and margins, or do we put that in the category of external outline?
It's wrong.
It's in catastrophic error.
It's a catastrophic error.
Because you failed.
Right.
You got it.
So we discussed this yesterday, right? So the student obviously addressed parts of the preparation that may or may not have needed to be addressed. Where do we address that? And obviously we have to give the student a B somewhere, but where does that go? And how do we address it?
Hello. Not much. I'm on a and Zoom calls.
Oh, I think
It's a fail.
they did not get
The calibration,
start check for
you know,
areas
Zoom
that they
call for,
prepared, therefore they
for
failed
teaching. It's
from
just-
the jump start. Now
Okay,
you need to prepare the tooth and restore it appropriately
okay,
in terms of a test case,
Oh,
because
she had,
you prepared areas that you did not.
she had reconstructive.
now fail.
okay.
That's an automatic failure.
That's an automatic failure, no matter what category.
Side and say, you understand this is a failure now. You need to restore it appropriately out of your shot of the patient. That's how we manage this.
Yeah, so those of you on Zoom, Nancy's question was, how do we manage this in front of a patient with a student? Letting the student know that they over prepped the tooth in areas that may or may not have needed to be prepped without an extension. And that they needed to properly restore it. But without earshot of the patient. Does anybody agree? Anybody have questions that this would be, that the student would fail at some category?
I just have a question. So on the rubric and grading, do we go immediately down to that failed test case and just click that and not grade anything?
Well, that's a good question, and
Situation like this?
yeah, and we brought this up to, you know, for this finish of walls and margins, that we're in this specific category. But where do we give that B, and do we assess, you know, the preparation with what they have prepped or their feedback? But then, you know, give that B down at, hey, you know, this was prepared unnecessarily.
Diane has a question.
No, Diane.
Can you guys hear me?
Yes.
Great. I have to say something here because I don't want us to be in conflict with what is on the online calibration. And one of the key concepts of doing criterion referenced evaluation is to start at the top of the rubric and work your way down. Don't look for a problem and zero in. What that does is it introduces a lot of bias into our assessments. So I think the conversation is really good. I made the mistake of looking at those two little holes and saying, oh, this is a T right away. But then I realized, oh, it's the finish of the walls and margins. It doesn't belong in this category. It belongs in the next category we're going to talk about, which is the extension in the external outline form. And so I would strongly recommend that we follow the criteria, start at the top, read the criteria very carefully, and apply it as consistently as you can.
Thanks, Diane. And you're right, that's where we're assessing, you know, wanted to focus on the walls and margins in this case. And then, you know, go with that external outline. Okay, Rodrigo, let's move on. Thanks, Diane. So Nikki, that was to your point of
Yes.
giving feedback for what the preparation was and then addressing the error.
Saying external line.
I think, can we skip that one?
Okay, let's do.
We're gonna skip the next one because we just talked about it. Okay, so this is kind of to our point where we've got a couple of those situations where we're asking for extensions where we can see the start check. So this left picture is the beginning start check. I'd like to do an occlusal class 1. The student calls you over, it shows you the middle picture and asks for an extension. Would like to obviously do caries removal and go through the oblique ridge because they think the caries is going to go through there. Faculty agree. And then what you see on the right hand side is the end product. So 3 stages, appropriately ask for an extension, and then we're grading the end preparation. And here we're looking at the external outline form specifically. And you can see that obviously they've got the larger preparation, but again, there's a little quasi prep out there as well, so. All right, ready? Go. We've got a big variation in this one. I think we had a lot of discussion about this one yesterday as well. Who wants to start kind of some discussion about how we might go about and what the external outline? Andrea.
No, I'm asking who gave it.
Oh.
70% of online was apart.
70% was online on R. Mr. Johnson says a T.
I don't think that should be a prep on the left there.
Okay.
Just ground it off.
Okay.
No filling there at all.
Okay. So the quasi prep was maybe not necessary.
You talk about 1/4 millimeter.
Here.
Yeah.
Right. And the student asked for an extension here, but didn't say anything about the little spot there. And they had touched that little spot, right?
So Amy, the
John is changing his answer. Okay, so the student didn't say anything. Okay. So would your answer change if, let's say, the student asked for an extension and says, I'd like to touch that little pit there because I think that there's caries there, and the faculty agreed that there could be caries underneath there, and this is what the student came back with? Would that change your answer? There is no caries there. Okay, so-
There were no caries.
Okay. Good. All right. Any other comments on the other prep?
It seems that it's carried on the TJ final prep, they're supposed to be ready.
And that's kind of hard to do it without.
You know, I didn't
Yeah.
check,
Okay. Good.
Okay, let's go.
All right, class 2, we've got a few class 2s. All right, so I'm gonna prep a DO. They have not asked for an extension. You ask them, are you ready to fill? It's your final answer, and they said, yes, I am ready to fill, and I would like to fill it as is. And that's what the student shows you, so. What do you think? In this, we are doing internal outline form this time, so those are different categories, so we're assessing internal outline form, specifically the caries removal. So, ready? Go. Oh, everybody in the red card, okay. But so, does everybody think that there's caries still at the DEJ? Okay, good. All right, where we go?
We don't get like something like here 45, 27,
Okay.
27 here. So this is pretty much where we went to a V, a solid V. Okay.
Solid B. Okay.
Yes. Let me change and then.
So this is the next picture. So let's pretend that middle picture that we all just gave a V on, that the student did that particular preparation and says, I still have caries, I still think I need to extend it. And this is what the end product was. And we're assessing internal outline form on this particular preparation. Go. Dr. Bitch, can I single you out?
No.
Yeah.
You're talking about it. You're talking about it. Why did you give it a T? I think it's overextended for the amount of caries that was.
Okay, so overextended
I think
how?
you still have some unsupported enamel.
Yeah, but I think overextension is external outline, right? Not external.
So internal outline.
Okay, I think there's, they got a little crazy with their caries removal.
Okay, so you do think it's overextended internally,
Yeah.
probably,
I think they
okay.
leaned on their down curl.
Okay. Dr. Jen,
Yes, and there's a for the margin, there's an unsupported enamel.
Yes, that's correct. That's
So
correct.
in that case, we give the T or give B, or just give S.
So that's gonna be under your external
Extend.
outline. So for internal outline, so if we're discussing internal
Or
and then we're gonna,
internal,
yeah,
I think it's a too close to pulp.
too close to pulp, so you agree with Dr. Bitch? Okay,
Okay. Online. we got-
online was R and S.
Yep.
All right, I don't have an external outline question, poll for this one, but since you brought it up, let's do it. External outline,
Okay, well, start.
Go.
Okay, close this guy.
so T's. And I'm not letting Dr. Vidge grade anything I ever do. But that's okay. Okay, so some B's, so meaning so anybody who gave a T, why not a B?
Look at that, you got 100% agreement that's home.
Oh, 100% S, and we're in the T and B category here for external outline. Dr. Jen,
I'm looking the, the literature about, the unsupported enamel in for the composite, not for the, the amalgam.
Yeah.
So in that case, so if, that's, just a discussion, I don't have the answer. So for this case,
She's provost, yeah.
it's okay or not?
so unsupported enamel, is it okay?
There
for
is some,
composite?
evidence to show if we did, the prep like that, for the composite, for the long term. It's not good, or it's the same as, the fitting without, unsupported enamel.
Rodrigo, do you? So, let me make sure I understand your question. So is there evidence that in a composite preparation, in a
Yes,
composite
that,
restoration, that amount of unsupported enamel
Yeah.
would be clinically acceptable?
Yes.
Yes, in the long term, have the good, outcome.
Okay. I don't know if I know that answer to that. Anybody else want to
You can have some unsupported enamel in composite restoration, but in a case like that, you would have to test the pollution and check if it's close to the margin and etc.
In the marginal range, if you have like a ridge less than 1 millimeter to unsupported, most likely in the long term, you're going to compromise the restoration.
Yeah.
So the location of the contact and the marginal range is mandatory to design your prep. Even you try to be conservative as much as you can, some of them you're going to compromise your composite. You can do the build up. I don't know, and there is not a lot of clinical trials showing how long they last comparing if you open the box as ideal prep. So there is no ideal prep in clinic anymore, but this is something that I probably want to concern a little bit in the marginal range, that unsupported area here. Not going to be like a major problem for the patient in the future, but I think you're going to compromise the long-term durability of your restoration.
Dr. Johnson?
I tell students, if I see that as a prep, I'm saying if you put amalgam in there, they're probably talking about 90% failure. Now, if you're gonna put a composite, you might be talking about 75% failure. I could be wrong in what I'm saying, but at least I'm giving them an issue to think about.
Thank you.
But this can be easily fixed, so
Yeah.
what I gave a T is because the overextension. Just this amount of the support of the demo, I would give an S because it's very easy to fix, it's minimum. My T came from the overextension compared to the other practice first one.
Okay, so did everybody understand that what Andrea was saying, that you also thought it was overextended?
So Amy, there is a
Yeah.
question and a comment here. The
Mhm.
question is, do we inform the student they failed in the middle of the procedure, or should we have them complete the procedure and then discuss with the student?
That's a good question.
I think it depends on the situation.
I don't think that there's really a right answer to that.
If you're gonna cause some damage,
Complete the procedure.
Yeah.
yes.
I'd like to chime in on that regarding when to notify a student of failure. I think notifying in the middle of a procedure can cause just a disastrous downturn. So I think it would be more beneficial to them and the patient specifically to wait until the end, as long as they can finish the procedure.
Right.
And most likely it needs correction. You're not. And if you see that the error, that the critical error, you're gonna need reassess a preparation or a restoration. You're not gonna complete your procedure, you're gonna do incomplete and tell the patient, you need to come back because we need to readdress this and this and this. And the student at that point, when you ask them, can you please put an incomplete, they know they failed. And then you can go over and say, okay, you failed here, bring the patient back, and then we need to correct.
So there's a comment too from Carolyn. I don't put students in double jeopardy with internal and external outline deficiencies if they are for the same reason.
We don't do.
No,
Correct.
nobody does.
Which is very important.
Yeah, thank you. All right, we have one last, and then we can open it up for any other, oh, no, we have two.
Yeah,
Let's go to the last.
but this one is a nice one to discuss here in like the overextension. I
Okay.
don't know.
Okay, so Barbara, you remind me what we were, so the student wants to, shows you this on the left, right? So this is their preparation for their DO. And, yeah,
Yeah, and like,
And then he comes, next time they come and check, that's what he had. on the
yes.
side.
So he asked, so you
He
decide,
asked for-
okay, I've got the carries out, which is true, but the preparation needs to be modified. So you ask the student to modify the preparation so that it's more acceptable for a restoration. And that's what comes on the left. So we're just kind of pretending that the restoration
Yeah.
ends up where that outline is. So now we're looking at the external outline of that particular preparation. So how would you assess that external outline?
This is what we are judging now,
yes,
external outline.
yes.
Ready?
A bunch of people here.
All right, anybody want to comment? Anybody think that that external outline on the right side is appropriate? Or anybody think that it is very overextended or moderately overextended?
I think it's extremely overextended.
Yeah, we disagreed about this one yesterday, so,
I think it's moderate.
okay. I gave it a T yesterday.
Thank you, Amy, I'm not alone.
I am agreeing with you, that was my answer yesterday, we did discuss it. Dr. Ryan, do you have a comment on this one, what do you think?
I think it's overextended on the left.
Hmm? Think it, it is a failure overextended or moderately overextended?
It was a teach.
What's the Zoom people say?
The Zoom people said most likely T, 6% of the T.
Good. Okay, now we can get to the last one. All right, so this one is external outline form. So we're looking at the external outline. There's two things here that we could discuss. Are you ready? Go. Some B's,
There we go.
some
50%.
S's. Dr. Bogro's got a V up, nodding his head.
Overextended.
Overextended,
Damage changes.
Yeah.
yeah. So there's damage to the adjacent tooth. So does everybody kind of, that's where the external outline form goes into place. And I'll even argue that that the student didn't address this.
Yeah.
So you could really even say it's underextended in its relationship to the caries, but overextended with the damage of the tooth. So, both of those could be addressed in that same category. Again,
Yeah, I have one question here. In terms of the size of the, in the product, when we do the, the cocktail.
I'm sorry, the dovetail?
Yeah,
Uh-huh.
so dovetail, prep, when we just use the, the slot press like that. Do we have some, the criteria for that?
So I think that we've all agreed that the dovetail is necessary when the caries extends into that occlusal groove, and the caries removal is necessary in that particular spot. So, but you brought up a really good point, because specifically, and I think we talked about this yesterday too, is that this is a slot prep here, but there's an extra carious lesion over here. And these could be technically considered two separate preparations. But that kind of goes back to what we were discussing, is that whole tooth really needs to be treated, right? And that the caries need to be addressed. So this is a situation where the student will say, but I'm doing a DO and I should only be graded on the DO. Say, well, you missed the caries, they're on that mesial pit. So that to me is part of recognizing the caries in the case, and that needed to be treated as well and recognized.
So for the, the slot prep, look like that, for me, I think it's too big. And that prep cannot provide enough retention. That's my concern.
So you're also concerned about the retention in that?
Yes, that's what's the, my concern. Maybe, you guys have more experience than me, and then you said it's okay.
Rodrigo, are you concerned about the retention in that?
No, we're gonna talk about retention, so, and we have a lot of evidence showing today, have a retentive preparation for composite in the long term is not as good as you don't have retention, because your retention is gonna rely to your bonding. So you have some retentive preparation to retain your composite. If you have a lack of bonding, you for sure are gonna have some secondary caries I'm gonna say, I don't know, depends on the risk of the patient, and where is like in the cervical area, probably gonna have some micro linkage, and the restoration gonna be retained there. So when you're bonding, the retention, we didn't even grade about retention, because for composite restoration, retention relies 100% to bond. Or you believe or not believe in bonding. So this is something that we can discuss in the restoration part, and I'm gonna bring some evidence showing. So we don't have any kind of feature to create more retention. You're gonna do very specific caries removal, defective preparation, and then you need to get a nice isolation, good sealing, and appropriate restorative technique. This is your bond. This is your retention.
In the understanding, maybe I'm understanding is wrong. So no matter how big of the the decay or the time, just use bonding, we are okay. That's correct?
Yes.
Okay.
Yes. This is what we're teaching.
Okay.
Based on evidence, yes. We don't do ideal prep for composite.
Okay.
We just do caries removal or selected caries removal, and part to the restoration is relied on your body tech.
Right, so that's all the cases that we have for our little flashcard. I want to ask, is there any, next time that Rodrigo and I present, we will be looking at the restoration part of the class 1 and class 2 test cases. If there's anything that we didn't bring up as far as, there were all good questions about protocols when you inform your student, you know, the student that, you know, they failed after, you know, those kind of things, we can discuss. I think that was a really valid question about the MO and the DO, if they have both. I think for now, we're considering treating the whole tooth at that particular appointment, that needs to be finished. And then we will be talking about case criteria, case selection. And when is it okay to say, okay, that's a failure based on case selection? So I think that that's gonna be an ongoing conversation for next time. But if you think of anything else that you have questions about, or you know, scenarios that have come up in clinic, please let us know next time. We'll be discussing the restoration part of the posterior test cases.
And I'm gonna ask you guys, please bring your camera, take photos, give to us, share what you got in the clinic, because I'm trying to do that very often. And as you remember, like the first calibration session that we did like back in September, I don't know what you guys are thinking about. We are in the same boat. We are not against each other. We need to move forward. No matter you agree or not disagree, you need to come to the end of the day, put in the table, say, okay, we are teaching, what is our vision?
And to Diane's comment, to go through the criteria, I think Suman brought up, I think Nancy, you had put some of the rubrics in the clinics, the paper copies of the criteria.
I don't know.
Yeah.
You can bring them up on a big screen.
Right.
Yes.
Right.
Very soon, I think after the break, each clinic you're gonna have a huge manual, restorative manual with all the test case criteria. Yes, we are pretty much like we are finalizing that. Was Margarita revised, I revised, Rome, Jack, and I think now we're just in the training and formatting process. So we're gonna have like a big one if we have any like concern. So you're gonna be like 100-something pages that are gonna be available in each clinic by one of the faculty ask for Jack to do that. So we're gonna have a binder with all the information.
And if you think it's helpful, we have copies, so that if you're grading this with a fellow faculty, you can have it right on that touchdown space, and you can make comments right on that sheet, and even hand it to the student before they leave. So that's been helpful to me as well. And just a reminder to identify which faculty member is responsible for grading that, because those students know that they're not going to get a good test grade. We have had problems with those students not submitting their self-assessment and trying to track them down for that. So communicating and making sure that you're in line with the faculty and which one is going to be responsible.
And so the students, then the
Yeah.
student.
Yes.
We're gonna have intraoral cameras.
Yeah.
So a consideration for future test cases. So there'll be about 20 of them for checkout from dispensing. You may have noticed the little mounts are being added on to chairs. So we're gonna have intraoral cameras, and we're also purchasing new extraoral cameras. Ours have outlived, they're 16 years in use.
Yeah, they're done.
So something to consider for the intraoral cameras.
Rodrigo, it might be possible for the future to save some of these images, maybe with some explanations that we can post in Canvas, my tools. So for new faculty, even for old faculty, they want to refresh their criteria and see where we are.
So what I'm trying to do, and everybody's welcome to join, we are trying to get like, Em and I are gonna lead some of those sessions. We're not leading anything, just like everybody else works. But we're trying to get together, try to do like an outline of the presentation. I showed to Jack, and then we say, get the green line, go. And we invite some of the people from preclinical and from the clinical teaching to come to us to do like a pre-calibration. So this is a lot of work to put together.
But we can do that, and then based on our comments, like we have here, we can translate that for the final file to share for the whole group, and then probably put it like in the onboard process in Canvas. Yes.
What will the majority of faculty, the rating that majority of the faculty come up with? So most of the faculty thought that this was a lead, which is that, so we know.
Yeah, just another thing, but again, I think some of this, what we need to do as an exercise, to record the code. I'm not able to record all the answers that we had here, but I think we need to revisit that and reassess and see, okay, now, what do you see? Do you see the same thing that we saw like 3 months ago? Maybe we're in trouble, so let's go move forward and see if you get to a point, to a good agreement. But Carl's idea, I think, is good. You just get like the file, make some notes, what the group said, and after the calibration, get the information that we share here between us and put in the file to share with everybody else.
So what I envision doesn't need to do exactly that. You put an image, you ask the person to watch the image to a score, right? And then after they do the score, you provide the score that was the consensus score of the group and explain why. You know, we found these issues here, and there, so this person learned what is the thinking of the group.
Okay, good idea. Okay, good.
Can I just make a comment? Like, I know we are ending the session, Marcia over here via Zoom. I think it will be helpful when you're doing the calibration, if you can share the consensus of the group that is organizing everything, because it will be helpful for us to know how you are evaluating. So we are going to be more calibrated when we're doing our evaluations in clinic as well.
Yeah, at that point, we are trying to find a consensus. So we are striving for a consensus. So we are going to try to organize some files, and we can share some of that information that we did during the pre-calibration with our comments. But I think we can be more systematic for the following ones and try to get a consensus for each one. Maybe put it down less clinical scenarios and be more specific. Let's talk about external outline, internal outline, 2 or 3 cases only, and then we can really share, because you see we are hurrying up just to finish the discussion.
Yes.
I'd like to know why there's a distinction when the students are graded on the boards. Why is there a different calibration or different criteria in what we're teaching? Shouldn't it be consistent? I see a lot of inconsistency. We're teaching something, but when they take the boards, they have to do something else. It doesn't make sense.
They're teaching them to treat humans, and the board is in a plastic tube, so it's kind of impossible to have the same thing.
But I think the intention is to try to minimize or eliminate discrepancy between the two, unless there is a good reason why we shouldn't do that. I can give you an example. About 10 years ago, the boards were accepting issues that were radiographically only in enamel. We wouldn't allow them to do that here because that was contrary to evidence at that moment. The board moved on. Now it changed. It's closer to us.
The board has to change.
Right. So I don't think we try to disagree with the board. We try to be in agreement as much as we can. Sometimes it's not possible for everyone.
So it's about time to wrap it up. I want to thank Amy and Rodrigo for putting this together. And all of you that helped out, Andrea, Suman. This is a lot of work to put together. This was very good discussion today. I think that we started this conversation, and I think that as we move forward now in the next calibration sessions, we'll probably get a little bit closer to each other because we are understanding more of what we expect. But it's really important. It's really important that we come close together as a group as we evaluate our students. So thank you all for being here. You're going to have a recording of this available either tomorrow or the day after tomorrow. It's going to be available. We are going to share with you the link to the recording. And our next calibration session is going to be in January 31st. It's January 31st, but we are not going to have one in December. If I don't see you, have a wonderful, blessed Christmas and holiday season. And
we'll reconnect again in December for calibration sessions. Thank you.
Was it on? Yeah. I didn't think it was. Audience participation.